Right. Now we'll continue with the metabolic actions of sympathetic nervous system or adrenergic surge in the body under the stress. Right. So let's talk about that. Here is your circulatory system. The metabolic role is played by the liver, and then these are your adipocytes here, which are also called, what is the other name for adipocytes? Lipocytes, or simply you call them fat cells. They are full of vacuoles, and these vacuoles are rich in triglyceride. Is that true? Triglycerides are there. This is glycerol and this is fatty acids. 3 fatty acids with 1 glycerol is triglyceride or triglycerols. Now, then of course we should not forget our friend. There is a pancreas, isn't it? And pancreas is islets of Langerhans, and in it has alpha cells and beta cells. You know it. Especially beta cells of the pancreas, they are concerned with production of. Normally they produce insulin. You must be knowing that here is a hepatocyte, a typical hepatocyte, right? Normally what happens that hepatocytes are taking up the glucose. They are taking up the glucose, isn't it? Then we'll see what is the effect of the sympathetic. First, normal physiology and biochemistry. Glucose is taken up by the hepatocytes, and this glucose may go into one pathway which convert into formation of, what is it? Glycogen. This is a polymer of glucose or glycogen. And this pathway which is taking glucose to the formation of glycogen, this is called pathway of glycogenesis. Then under some circumstances what really happens, glycogen is broken down into glucose. Is that right? And this pathway is called glycogenolysis, right? Now, what I was talking about, normally liver cells, when they take up the glucose, they polymerize the glucose and make the polymers of glucose which are called glycogen, and this pathway is, this upward pathway from glucose to glycogen is called glycogenesis. Then under some circumstances what really happens is that glycogen breaks down into glucose, and this pathway number 2 is called glycogenolysis, and this pathway can result in release of glucose to circulation. This can result in release of glucose to circulation. When sympathetic overflow occurs, you need more energy fuels in the circulation or less? We need more. So it means the level of glucose in the blood must go up. Number 1, level of glucose should go up. Number 2, another form of fuel is free fatty acids, and their level should also go up. Now, how this thing really happens when sympathetic overflow is there and epinephrine is circulating in the blood in a higher number? Let's suppose here is your epinephrine. Now what epinephrine is going to do? Number 1, epinephrine act on the receptors which are present over here, and these receptors are called modified beta 1 receptors, which are called beta 3 receptors, right? When epinephrine or adrenaline stimulates beta 3 receptors, right, this stimulates certain enzymes, and these enzymes start breaking down the triglycerides, right? So it means that epinephrine act on the beta 3 receptors of the adipocytes and lead to lipolysis, breakdown of the lipids. And what will be the real result? When this lipid will break down, what will come out? Glycerol and free fatty acids. Now this free fatty acids will come into circulation, free fatty acids, and they will increase the concentration of free fatty acid in the blood. Of course, this is a fuel molecule which is added to the circulation. This is one point. Secondly, this free fatty acid has one very important function, that these free fatty acids can also go to the liver, and this may lead to the formation of more glucose. And the glucose which is made from non-carbohydrate sources, again, this glucose is coming from the breakdown of alteration in the skeleton of free fatty acid, right? Again, let me repeat it. When epinephrine surge is present in your body, especially for a long time, it's a big dog after you and you're running and running and running, what really happens that free fatty acids start releasing from adipocytes. Number 1, free fatty acids in the blood, when their concentration increases, they act as a ready fuel. Number 2, these free fatty acids are taken up by the hepatocytes, and hepatocytes start producing glucose from such sources which are not carbohydrate. I mean, fatty acid is not carbohydrate. So when you can say any tissue is synthesizing glucose from non-carbohydrate sources, we call the glucose is being formed from new sources. Glucose is being formed from new sources, or we simply call it gluconeogenesis, right? Gluconeogenesis, number 1. But before the glucose really appears into blood due to gluconeogenesis, more rapid release of glucose occur from the liver due to breakdown of glycogen, because the pathways which are concerned with glycogenesis, they are inhibited. It means pathway number 1 is inhibited and pathway number 2 is stimulated. So it means that when adrenaline is high amount, then adrenergic receptors which are present over here, they give signal in such a way, these are again beta 2 receptors, they are giving such signals that formation of glycogen from glucose is reduced. So we say that in the hepatocytes, intracellular metabolism is altered and pathway concerned with glycogenesis is inhibited, and pathway concerned with breakdown of a glycogen, which is called glycogenolysis, is activated, and then liver will start pouring out more and more glucose, and this glucose is coming from carbohydrate sources, of course. So this is one thing, that what we have done up to now, that metabolic action by acting on the lipid cell, it has increased the free fatty acid concentration there, it has provided the raw material for gluconeogenesis, plus it has directly acted upon the hepatocytes. Epinephrine has directly acted upon the hepatocytes and increased the release of glucose from the glycogenolysis. But one more thing, we want to keep the glucose level high in the blood. Under these circumstances, then glucose release should be more, insulin release should be more or less? Less. Because listen here, if dog is after you and unfortunately if you release more insulin, then a lot of glucose will shift to the peripheral tissue and you will suffer with hypoglycemia, and of course that is not a time to suffer with hypoglycemia. So it means that level of insulin in the blood should be high or low? Yes, it should be low, right? And if insulin level is going to be low, it means the beta cell of pancreas are going to be stimulated or inhibited? They are going to be inhibited, and inhibitory adrenergic receptor which is present over here is alpha 2 adrenergic receptors. So this is very funny that beta cells are having alpha 2 adrenergic receptors, so that when epinephrine knocks at the door of this, it stimulates alpha 2 receptors, it inhibits the further release of insulin. So what really happens in the body? In your circulation, free fatty acid levels are going up, glucose level is going up, and push of glucose through the insulin has been reduced, so that fuel molecules present in the circulation can be maintained at a high number. Another interesting thing is, okay, that I will not discuss right now, right? These were some important metabolic actions. Some people even talk about the release of potassium from here. Do you know this thing? What is the need of potassium releasing from the liver? I am about to be impressed by someone. Does the nature want to kill you with hyperkalemia or some other reason? Look here, actually skeletal muscles are working very hard, and when skeletal muscles are working very hard, lot of action potentials are passing. During every action potential, what happened? During depolarization, some sodium goes in, and what really happens? Some potassium comes out. Is that right? Number 1. Number 2, it means potassium is coming from here out as well as it is coming from here out. Is that right? Now, this potassium should be immediately shifted to another reservoir, and actually this potassium is pumped to the muscle. Who will push the potassium to the muscle? Remember, usually glucose and potassium move together. They're just like boyfriend, girlfriend. Glucose and potassium usually move together, right? When glucose was coming from here, potassium was coming also along with it. And when glucose is being shifted to the muscles, what will go along with it? Potassium. Is that right? But as I told you, that due to repeated action potential in the muscle as you are escaping from the dog, more and more potassium is leaking out during every repolarization. You know, during depolarization there is sodium influx, and during repolarization there is potassium efflux. Do you think this potassium should be allowed to stay outside, or this potassium should be pumped in back? Answer is yes. So, who will take this potassium in? Yes, please. Sodium potassium ATPases. Before you tell me something new, the pumps are, have you heard of this? Sodium potassium ATPases. These are present in which cells in the body? Sodium potassium ATPases, yes. Every cell. Sodium potassium ATPases are present in every cell, but actually this sodium potassium ATPases, they are very, very sensitive to epinephrine. Even epinephrine increases the activity of sodium potassium ATPases, so that due to action potential, whatever potassium is coming out, it should be again pumped back. Am I clear? So these were some changes, electrolyte and metabolic changes in the person in which there is sympathetic activity. Let's sum it up, recap it. That a person who has severe and prolonged sympathetic overflow, right? What will be the metabolic changes? He needs more fuel molecules in the circulation. So number one, epinephrine will act on the liver and break down the glucose, and there will be lot of glucose appearing in circulation due to glycogenolysis, number one. Number two, epinephrine will act on the beta cells of pancreas. No, it will act on the adipocytes, and there will act on the beta 2 receptors, modified beta 1 receptors which are beta 3 receptors, and when epinephrine will stimulate beta 3 receptors on the adipocyte, that will lead to stimulation of enzymes which will break down triglycerides, and free fatty acids will come into circulation, another form of energy. Some of this free fatty acid will be taken to the liver, and there it may be utilized in the process of gluconeogenesis. So blood will become rich in glucose due to breakdown of glycogen or glycogenolysis, plus due to gluconeogenesis. Now this level of high glucose should be maintained in the blood, right? For this purpose, epinephrine also goes to the beta cells of pancreas in the islets of Langerhans, and there it inhibits the release of insulin, so that whatever level of glucose is being maintained, it should not be pushed to the peripheral tissues unduly. Meanwhile, as I was stating, that usually, not always, but usually potassium and glucose go hand in hand. That is why a lot of glucose is shifting out of liver to the circulation. Some potassium also comes, right? But of course, it should not lead to hyperkalemia. Why? Because as soon as a lot of potassium is appearing here, meanwhile if muscles are working, then naturally a lot of potassium is also appearing during repolarization here, because in the muscles number of action potentials are more than normal, right? So potassium coming from here and potassium coming from here, this increases the risk of hyperkalemia, but actually hyperkalemia does not occur. The reason being that epinephrine has effect on the sodium potassium ATPases, and whatever sodium is going in during depolarization, it is thrown out, and whatever potassium is outside, it is thrown in. Is that right? Now a few words more about the another special function of adrenergic stimulation. You know, in the muscles, skeletal muscle, there are extrafusal fibers, and along with the extrafusal fibers, yes, what are these? Muscle spindles, which are also called intrafusal fiber, right? These intrafusal fibers, right, they determine, you know, they are playing a very big role in maintenance of tone, right? Now, and you can say that intrafusal fibers or muscle spindles are sensory system of the muscle. They sense the stretch in the muscle. All of you must be knowing that. Muscle spindles which are present in the muscles, they are actually stretchometer, they measure the stretch of the muscle. If I can maintain, look here, if I can maintain my hand like this and without tremors, it means the, yes, muscle spindle present in this group of muscle, agonist and antagonist, they are working very, very accurately and providing the degree of tension and rather degree of stretch in the muscle in a very accurate fashion to the central nervous system. Again, listen carefully. We say that when adrenaline level goes up, you may develop the tremors. Why it happens? I'm going to answer it. But first we talk about the basic fundamental, that why a person with normal level of adrenaline or low level of adrenaline can keep his hand steady. It's very simple. When you are keeping your hand steady without tremors, it means that tone in the flexors and extensors is absolutely equal and it is extremely well regulated. Now, central nervous system is supposed to control the tone in the muscle on both compartments, and this tone should be maintained equal. But central nervous system will only control the tone on both sides only when it has accurate information about the degree of stretch in the muscle. Is that right? So normally what happens in a healthy person, muscle spindles are working very finely and updating lot of data to the central nervous system. Of course, we call it proprioceptive information. Lot of proprioception from the muscles is going to the central nervous system and it is processed in the cerebellum, and cerebellum will, and many other extrapyramidal centers will control the, you can say, degree of tone in both sides and degree of contraction in the both sides of the muscle, so that there is no tremor. Once you have learned this very clearly, what really happens, that when adrenergic surge come up, epinephrine has its receptors on the muscle spindles also. Epinephrine has its receptors on the muscle spindle as well, and there are, when epinephrine comes to the muscle spindle, it will stimulate the muscle spindle as well. And when muscle spindles are overstimulated by epinephrine, then muscle spindles become desynchronized. They don't work well, right? And what is the result? That information which is going from both sides of the muscle to the central nervous system, that may not be as accurate as it should be. The basic purpose of epinephrine was to make the muscle spindle more functional and more accurate. But actually slight increase in epinephrine will make it more accurate, but when there is very high increase in epinephrine, muscle spindle will become dysfunctional. And you can say muscle spindles are the eyes of the muscles. CNS sees the muscle activity through the central nervous system, senses the muscle activity through the muscle spindles. When adrenergic activity disrupts the function of the muscle spindles, then central nervous system cannot be updated properly about the sensory input coming from the muscles. If sensory input from the muscles is not coming properly, can central nervous system really regulate the degree of contraction in both compartment, agonist and antagonist? No. So what really happens, that when you are very angry or you are very much fearful, you develop tremors, because even if you want to hold your hand very steady, you cannot, because muscle spindles are not giving information properly and central nervous system is not you can say coordinating the information. Sometimes how the tremors occur. First, maybe this overfires, it will go down. Then other group will overfire to correct it, it will go up. Then another group overfires. So there is undue overfiring from different groups of muscles, and that may lead to uncoordinated, you can say, degree of contraction in different compartments, and hand cannot be kept steady without tremors. Am I clear? Now, all this explanation, what's so fun to learn this explanation? The fun is that, of course, as doctors, you must know why people develop tremors when they are afraid, or why people get tremors when they are, yes please, they are angry, or why people develop tremors when they are anxious. Is that under all these circumstances, sympathetic overflow is more. Number two, as good doctors, you must also know why people develop tremors when they are having thyrotoxicosis. Yes, what is the relationship of thyrotoxicosis with the sympathetic nervous system? Yes, please. T3, T4 level in thyrotoxicosis goes up. How it alters your sympathetic activity in the body? Yes, please, doctor. We are talking about, if I am a patient with thyrotoxicosis, right, I may develop many features of sympathetic overflow. I may develop tremors, I may develop anxiety, I may develop lead retraction, right, and may develop tachycardia. How thyrotoxicosis can lead to increased sympathetic manifestations in the body? Yes, please.
Since hormones are going to increase every metabolic activity in the body.
It is going to increase the?
Every metabolic activity in the body and nervous system is also stimulated by the hormones.
First thing she is saying that epinephrine will increase the central activity. Do you think if I inject you epinephrine, it will go to the central nervous system? No, because epinephrine cannot cross the blood-brain barrier. But when you are angry or you are having some trouble like that in thyroid, right, there is some adrenaline which is directly produced in the central nervous system, some adrenaline which is produced by the adrenal medullae and from nervous system, right? But remember one thing, peripheral epinephrine or norepinephrine or dopamine cannot cross blood-brain barrier because these are highly polar compounds. So whatever these neurotransmitters, for example, when you're angry, epinephrine level in the brain is high, that is locally produced in the brain. Is that right? Now we'll go back to our question. My question was that in patient of thyrotoxicosis, why there is increased manifestation of sympathetic activity? Yes, please.
The thyroid hormone induce the adrenergic receptors.
Excellent, very good. After a long time, someone gives such an impressive answer. She has said that T3, T4 induce the formation of excessive adrenergic receptor. More accurate answer will be that let's suppose here is a cell, any cell, and here is a gene for suppose adrenergic receptor. If this is a cell which is normally expressing this gene for adrenergic receptors, suppose this is alpha 1 receptor or beta 2 receptor, whatever adrenergic receptor is there, it will appear on the surface. You know, when T3T level goes up, T3, T4, T3 goes into cell, you know, it enters into cell directly, and receptors of T3, which are, when T3 stimulates its receptor of T3 will stimulate the genes. And basically, thyroid hormone, especially T3, enters into cell, and within the cells, they stimulate many groups of genes, including the group of genes concerned with the synthesis of adrenergic receptors. So what really happens in thyrotoxicosis, all the tissues which normally express adrenergic receptors, they overexpress the adrenergic receptors. So concentration of adrenergic receptor in every tissue which is sensitive to adrenaline become less or more? More, right? SC node become overloaded with beta 1 receptors, AV node become overloaded, right? Myocardium become overloaded with beta 1 in thyrotoxicosis. In the same way, muscle spindle also become overloaded with beta 2 adrenergic receptors. Is that right? So actually the patient who are having thyrotoxicosis, what really happens, there is no overstimulation of sympathetic nervous system. Actually sympathetic nervous system itself is not much stimulated. What is the real thing? That release of endogenous norepinephrine and epinephrine remains normal, but the target tissue of epinephrine and norepinephrine are hypersensitive to adrenergic drive. That is why there are sympathomimetic activity apparently in the body, and patient with thyrotoxicosis may develop, yes please, may develop tachycardias, or he may develop anxiety, or he may develop tremors and other manifestations of increased sympathetic activity in the body. Am I clear to everyone? Right? So I was saying, what is the fun to learn that why there are beta 2 receptors present on muscle spindles, and when they are overstimulated they may produce tremors. Another point which I wanted to highlight, okay, that I will not discuss right now, that when you are angry, epinephrine is more and tremors occur, or when you are frightened, epinephrine is more, again beta 2 receptors, more stimulation, muscle spindle go in dysfunction, right? Of course, there is some central action also, when within the central nervous system epinephrine is produced. Then I told you in thyrotoxicosis, there is excessive receptor expression on the tissues. Which receptors? Adrenergic receptors, right? One more thing. In this context, you also know, you should know that all the drugs which are beta 2 stimulant, they have a very important side effect, which is tremors. You know, drugs like salbutamol, terbutaline, albuterol, Ritodrine, yes, all these drugs are basically mainly beta 2 stimulant. Usually we use them to relax the bronchial smooth muscle, or Ritodrine is especially used to relax the uterus when uterus threatens to push the baby prematurely out, right? So in premature labor contractions we use Ritodrine, or salbutamol, terbutaline is used as a bronchodilator. So advantages of these drugs is that by acting on the beta 2 on bronchial smooth muscle, they do produce bronchial relaxation, but there is a disadvantage that these drugs will act on the muscle spindle and produce, yes please, they will produce tremors. They may act on the liver and other, you can say, adipocytes and produce metabolic problems. You may have heard of that salbutamol not only produces tremor, it may produce hyperkalemia, it may produce hyperglycemia, right, and other problems as well. Right? Any question about sympathetic nervous system? Because then we have to switch to the parasympathetic nervous system. Anyone has any question related with the sympathetic nervous system? About one more interesting phenomenon, that those tissues in the body which are having control by sympathetic and parasympathetic, both divisions of the autonomic nervous system, they actually work in a very interesting way. For example, this is some tissue in the body, and this tissue is, let's suppose, it's any tissue, it may be heart, it may be GIT or any tissue. Now this tissue is under sympathetic control as well as parasympathetic control. Now let's suppose that here is parasympathetic control coming. Naturally, parasympathetic control will release what substance here? Acetylcholine. Is that right? And this is sympathetic, and sympathetic nervous system is releasing which neurotransmitter here? Yes, norepinephrine. Right? Normally what happens, let's suppose this is your heart. Okay, this is your heart, but you don't have a black heart, isn't it? Okay, let me make it a big heart so that you can, should it be red or which color? Black heart, I don't like it. Okay, this is a, I will make heart over here, right? And here is SA node. And this SA node is supplied by parasympathetic as well as, yes please, sympathetic. This thing I will enlarge over here, right? So that is the SA node, and this SA node, one single cell I have enlarged over here. This is one cell of SA node. It is under adrenergic drive as well as it is under cholinergic drive. Is that clear? Now we have to see how it really works. As you know, that receptor which is present here, yeah, for norepinephrine is what type of receptor present over here? Beta 1. Remember, heart has beta 1, beta 2 as well as alpha 1 and alpha 2. But dominant receptor on the heart is beta 1. Dominant receptor is beta 1. So SA node is loaded with the beta 1 receptors. So it means norepinephrine will be stimulating beta 1 receptor. You know, when beta 1 receptor is stimulated, heart rate goes down or up? Heart rate goes up. We have to see how it really stimulates the SA node. And of course, when vagal stimulation comes, heart rate goes down. Again, we have to see at molecular level how it really goes down. Now, first thing which is there is, you know, beta 1 receptors are coupled with intracellular G protein. G protein, you know, G proteins are, yeah, what is this? It has alpha stimulatory part, beta and gamma unit. Now what really happens, norepinephrine stimulates the protein which is called G stimulatory. This is basically G stimulatory, right? When G stimulatory is stimulated, this is which receptor? Beta 1 adrenergic receptor. When norepinephrine stimulates this receptor will stimulate G stimulatory. I will not go into detail. You must be knowing that G stimulatory will lose ADP, acquire ATP on its alpha component, and that alpha component will stimulate a very special type of enzyme, and this special type of enzyme is called adenylyl cyclase. This is called adenylyl cyclase. Actually, this is present on the internal membrane, right? Now, when adenylyl, how? Basically, adenylyl cyclase will be stimulated. It has one special type of, you can say, ear. This enzyme has one special point where it can be stimulated by, yeah, what is this? G stimulatory. And when G stimulatory bind with this particular point, this will give a stimulatory signal to a special domain in this, and that domain will convert, yes please, ATP into cyclic AMP. So it means when norepinephrine or epinephrine act on the beta 1 receptors on SN node or AV node or myocardium, that lead to stimulation of G stimulatory intracellular proteins, and G stimulatory lead to stimulation of, yes please, adenylyl cyclase, and that will increase intracellular cyclic AMP concentration. Is that right? This cyclic AMP will drive an enzyme. There is an enzyme which is very, very sensitive to, yeah, cyclic AMP. This enzyme will take the target protein and phosphorylate them. This enzyme will take the target protein and phosphorylate the target proteins. Because this enzyme is phosphorylating the target proteins, this is called protein kinase enzyme. And because this enzyme is sensitive to the presence of cyclic AMP, so it is cyclic AMP, adenosine monophosphate sensitive protein kinase, so we call it protein kinase A. Protein kinase A mean, thank you, protein kinase A mean that enzyme which can phosphorylate certain proteins, and it is itself driven by A. A mean adenosine monophosphate, cyclic adenosine monophosphate. Now what really happens there? This protein kinase A will lead to phosphorylation of, look here, it will lead to phosphorylation of certain calcium channels. Let's suppose this is a calcium channel or cationic channels. Now, protein kinase A will add here phosphates. What it will add here? Phosphates. And when these channels become phosphorylated, they become functional. Again, let me tell you, it means these cationic channels are sensitive to the activity of protein kinase A. And what protein kinase A is doing, that protein kinase A will lead to, yes please, phosphorylation of certain cationic channels. And when these cationic channels are phosphorylated, they become overfunctional. They open up more frequently. When they are opening more frequently, the cations from outside will jump in, especially calcium and sodium, right? It means, especially calcium, it means when you release epinephrine on S node will start loading what? Cations. It will start loading cation. Again, step number 1. Action potential coming along the, yes, axon, leading to release of norepinephrine. Epinephrine will stimulate beta 1 receptor. Beta 1 receptor will stimulate G stimulatory. G stimulatory will stimulate adenylyl cyclase. Adenylyl cyclase will increase intracellular cyclic AMP. That will positively drive protein kinase A. Protein kinase A will lead to phosphorylation of many protein, including the cationic channels, right? Especially calcium and sodium channels. So when these channels become phosphorylated, they become over functional, and when they become over functional, there's cationic load increase into cell. Now listen carefully. If any excitable cell, you load the cations, resting membrane potential become near to threshold. It's very easy to understand, am I right? That in any excitable cell, if you load the cell with some cations, resting membrane potential will become more near to threshold. So it means cell will become less excitable or more excitable? It will become more excitable. So it means when adrenaline work on the excitable cells, it will load the excitable cells, especially with the calcium. When calcium waves enter into excitable cell, they become more excitable. When extranode cells become overloaded with calcium, their resting membrane potential become more near to threshold. So resting membrane potential will approach the threshold more frequently or less frequently? More frequently. So release of action potential from the SN node to the rest of the heart will be increased. Okay, let me draw that thing as well. Let's suppose in this cell, in this particular cell, this is the action potential pattern. Now what really happens? This is resting membrane potential, resting membrane potential. This is threshold potential. Normally how SN node activity occur? Some cations come in, take the resting membrane potential to threshold, then lot of calcium channel open, lot of heavy calcium influx occur, and then threshold potential go to complete depolarization. You know, normally cells are negatively polarized. Normally cells are negatively polarized. If lot of cations are put in, what really happens? The negative polarity is neutralized, and we say cells are depolarized. We say the cells are depolarized. What really happens? That normally how SN node work? SN node has leaky sodium channels. So whenever SN node come to resting membrane potential, it is not allowed to rest, because leaky sodium channel lead to some leakiness of influx of sodium. This sodium which is going in is simple leakage, not voltage gated. This leaky sodium channel will bring cation in, take the resting to, yes please, threshold. At threshold, voltage sensitive calcium channels will open, lot of calcium will come in, cell will become depolarized, and action potential is produced into this cell. That action potential is you can say conducted to the next myocardial cell. During that, lot of potassium will go out and it will be repolarized. As soon as this cell of the SA node come back to the, where it comes back to the resting, again some sodium will leak in. Again resting will go to threshold. Again lot of calcium influx will occur. Again potassium efflux will occur. Now, actually, during 1 minute, how many action potentials will be produced by SA node? It depends on what is the resting membrane potential level, right? And how much is the difference between resting and threshold. So that if, let's suppose, there is less difference, if resting membrane potential and threshold potential, if they are far off, it will take a long time to reach. And if they are near to each other, it will rapidly reach. Am I clear to everyone? Now imagine, if SA node is working like this and I add some epinephrine, the result will be that in the end, more calcium channel will open. There will be added cations. If there are more cations, resting membrane potential will remain very minus or it will become near to the threshold. Number 2, it will go gradually up, or cations are additionally coming, it will go rapidly up. So what really happens? Resting membrane potential has come near to threshold and the slope very rapidly achieved. So what really happens? Number of action potential produced are more or less? They are more. This is exactly what happens when you put epinephrine on the SA node. So let me repeat it. It's worth repeating because there's so many MCQs which are related with such concepts or based on this concept, that how epinephrine alters the excitability in SA node or AV node. If you understand this thing, it will explain all the excitability business in the heart. Now, again, number 1, you should know the normal excitability mechanism. All the excitable cells and conducting cells, these may be SA node cells, it may be AV node cells, it may be Purkinje cell, it may be myocardial cells, whatever these cells are there, all of them have some resting membrane potential and they have certain threshold. Basic principle is this: whenever resting membrane potential is more near to threshold, cells are more excitable. Secondly, whenever resting membrane potential can be more rapidly taken to the threshold, cells are again more excitable. Is that right? Now, what really epinephrine does? When epinephrine work on SA node, or it work on AV node, or it work on the Purkinje fibers, or it work on the myocardial cells, everywhere epinephrine leads to the calcium loading. Mechanism is same as it is here. That all of SA node or AV node or Purkinje cells or myocardial cells, all of them are decorated with beta-1 receptors. So epinephrine acts to the beta-1 receptor in all these cells. There is increased activity of G-stimulatory in all these cells. There is increased adenylyl cyclase activity in all these myocardial cells. There is increased cyclic AMP levels, and in all these cells there is increased protein kinase A activity in all these cells. There is excessive phosphorylation of their calcium channels, and calcium start overloading SA node, AV node, Purkinje cells and myocardial cells. And when all these cells become overloaded, all calcium dependent electrical and mechanical phenomena become accelerated. All calcium dependent electrical and mechanical activities become accelerated. For example, when SA node is overloaded with calcium, it will more frequently fire. When AV node is overloaded with calcium, it will more effectively conduct. When Purkinje fibers are overloaded with calcium, they will more effectively conduct, as well as they will become more excitable. When general myocardial cell like ventricular cells are overloaded with the calcium, they will more effectively contract. Am I clear? There's no problem. Now we have to see another thing, that how acetylcholine work in opposite way. It's easy to understand. You know, acetylcholine work on its cholinergic receptors, and type of cholinergic receptors which are present over here. What are the type of cholinergic receptors here? This is acetylcholine, yeah, M2. These are M2 muscarinic receptors, right? Now, when this is stimulated, they will lead to 1, 2, 3, 4, 5, 6, and 7. You know, there are 7 pass receptors. Like a snake, the 7 times turns to the membrane. Serpentine receptor we call them. Serpentine receptor coupled with the G proteins. Remember, adrenergic receptors are, beta-1 receptors are also serpentine. Muscarinic receptors are also serpentine. But its domain is, ligand binding domain is sensitive to norepinephrine. Its ligand binding domain is sensitive to acetylcholine. Its effector domain is stimulating G is stimulatory, and its effector domain is stimulating G inhibitory. So when it will stimulate the G inhibitory will stimulate another point here. Yes. What is this? Adrenalyl cyclase are 2 ears. One wife is talking in this ear, other wife is talking in this ear. One wife is stimulatory, other is inhibitory. It's just like that. Look here. This is adrenalyl cyclase. If this system is working, it is very happy and action is increased. But unfortunately, if this side is stimulated, it is not stimulatory action, it is inhibitory. You can make it like this. If muscarinic activity is more, then the other side is, but this domain, when it is stimulated, it actually inhibits the adrenalyl cyclase activity. When adrenalyl cyclase activity goes down, what really happens? Conversion of ATP into cyclic AMP is reduced. So it means when you put acetylcholine on the S node cell, what really happens? M2 receptors are stimulated. M2 receptors internal domain will stimulate G inhibitory. G inhibitory will inhibit the adrenalyl cyclase. Now look here, G stimulatory stimulate the adrenalyl cyclase, G inhibitory inhibit the adrenalyl cyclase. When adrenalyl cyclase is inhibited, level of cyclic AMP goes down, protein kinase activity goes down, phosphorylation of cationic channel goes down, and cationic loading in excitable cell is increased or decreased? Decreased. So in the presence of acetylcholine in S node and AV node, cationic loading is decreased. When cationic loading is decreased, it means total cations are entering are less. So resting membrane potential will move away from threshold, and the speed with which resting membrane potential can achieve threshold, it is increased or decreased? Decreased. So what really happens? Under the cholinergic stimulation, resting membrane potential has moved away from the threshold, and from here it will take a long time to reach to the threshold, and number of firing per minute are decreased. That is how epinephrine and norepinephrine produces tachycardia. Epinephrine and norepinephrine produce tachycardia, and acetylcholine and similar drugs produce bradycardia. Now, a good student know how the system is antagonizing. This is the unfortunate husband in between the two wives, and they antagonize at many levels, not only at personal level, many social level they antagonize, right? So we have to see these two systems, adrenergic system and cholinergic system, how do they antagonize? Because this is a classical example how one tissue is under being influenced by the one accelerator system and another brake system, and these biological accelerators and brakes, how do they work against each other? What is the first level of antagonism? Here, the wife have to fight with each other also. Not only it will stimulate this, she will also inhibit that. Is that right? When this is in power, adrenergic system, not only it will directly stimulate the tissue, affect the tissue, it will also have one synaptic button on the cholinergic nerve ending, and here it will release what substance? Norepinephrine. Do you think this wife is very happy to receive the norepinephrine message from other side? She cannot even see or tolerate the other wife. So what really happens? This norepinephrine will kharab mood, disturbed mood. How? This will have a receptor which is called, what is this receptor? This is adrenergic or cholinergic receptor? This is cholinergic ending with adrenergic receptor, and this receptor is alpha 2 adrenergic receptor. This norepinephrine stimulates the alpha 2, and alpha 2 receptor lead to intracellular. It is also coupled with G inhibitory, and this alpha 2 receptor eventually leads to what type of problem? This alpha 2 receptors, that inhibition of nerve ending. So what really happens whenever heart is under the influence of this wife, adrenergic system, not only heart is stimulated, but at many levels sympathetic activity will be antagonizing parasympathetic. How? Number one, some sympathetic nerve endings will go to the cholinergic nerve endings, and there they will release, we call it presynaptic nerve inhibition, right? At presynaptic inhibition, they will release norepinephrine, and this will be inhibited. The first thing. But of course, both of them are really sharp, right? And that is the only, what is this? Sometimes the time of this wife comes. Vagal activity is too high. So not only vagal activity will lead to inhibition of this man, she will reduce the excitation also from there, that it will have what type here? Vagal will have a nerve ending here, and this nerve ending will be releasing what? Acetylcholine. This is vagal nerve ending. This is the nerve ending which is going directly to the tissue, and this is, you can say, parasympathetic nerve ending, which is doing presynaptic inhibition of adrenergic nerve ending. It will be releasing what substance here? And what is the receptor here? Of course, muscarinic, M2. So this will lead to inhibition. So it means there is concept of reciprocal inhibition at neuronal level. There are sympathetic nerve endings, they inhibit the parasympathetic nerve endings, and when parasympathetic nerve endings are overstimulated, they inhibit the sympathetic nerve endings. Is that clear to everyone? This is one level of antagonism. Then what is the second level of antagonism? This is the first level of antagonism, right? They are inhibiting each other. Second level of antagonism, she has to work on different receptor, sympathetic nervous system, and she has to work on different receptors, even though both receptors are, what are these? They are serpentine, but this is adrenaline sensitive and this is acetylcholine sensitive. Now what really happens? This receptor is coupled with G stimulatory, and that receptor is coupled with G inhibitory. So it means that again they are antagonizing. If this activity is more, G stimulatory activity will be more than G inhibitory, or if this activity is more, than G inhibitory activity will be more than. So this is second level of antagonism. Third level of antagonism is unfortunate man. Both of them trying to fight. One is trying to stimulate, other is inhibiting. It means heart is all the time under parasympathetic and sympathetic influence. Normally your heart is under sympathetic influence, more parasympathetic right now. Normal heart is under more sympathetic activity, or in a resting man, or parasympathetic. Parasympathetic. The result, let me tell you the real experiment which prove it. Okay, let me tell you what is the real experiment. My heart rate is suppose 80. If you denervate my heart and bring it out of the body and throw into such culture and fluid which can support the cardiac activity, heart rate will go up. So denervated heart activity goes up. So it means that intrinsic activity of heart is faster than what normally we have. It means normally parasympathetic activity dominate on the heart as compared to sympathetic. Is that right? Anyway, come back. Third antagonism is at adenylyl cyclase. Fourth antagonism is at what level? Okay, or you can say counterbalance. That adenylyl cyclase is increasing cyclic AMP. There must be something to decrease cyclic AMP also. Adenylyl cyclase is increasing cyclic AMP, but there must be something there to decrease the cyclic AMP. For example, you hear some news and you become excited. Your heart rate goes up. Heart rate will remain up forever or only for a short time? That's a very sad part. It's only for the short time. Why? The reason being the cyclic AMP is not there for a long time. As soon as it is formed, it is being attacked by a special type of enzyme, and this very bad enzyme, right, it has a cutter and it cuts the cyclic AMP and break down its cycle. So it becomes AMP. And right? So this enzyme, yeah, what is this enzyme? This enzyme is responsible, yes, to break down cyclic AMP. So as soon as cyclic AMP is being formed, it is continuously being broken. That is why sympathomimetic activity never lasts for a long time, because the intracellular second messenger which is being formed, right, if sympathetic drive go down, then it will not remain there forever, it will be catabolized. What is the name of this enzyme? Question goes to, yes, Dr. Maliha. Excellent, phosphodiester. The name of the enzyme is phosphodiester. Phosphodiestrases. Yes, phosphodiesterases. These phosphodiesterases can be inhibited by something which Dr. Maliha drinks very often. What is that thing? Inhibited by something which you drink very often. Caffeine, coffee, tea. Actually, when you take coffee or tea or coke, these substances inhibit this enzyme. And if you are taking coffee and this enzyme is inhibited, you can imagine we can make this enzyme like this. And now this enzyme is very sad. Why it is so sad? Because cup of tea is present over it. This enzyme can be trapped into cup of tea. caffeine, coffee, methylxanthines, right? All these can inhibit this enzyme. And when this enzyme is sleeping and not working, even if your epinephrine is at normal level, but intracellular second messenger will accumulate as if there is excessive sympathetic overstimulation. That will lead to sympathetic overdrive to the tissue. But actually sympathetic nervous system is not directly stimulated by the T. What T is doing, that it will go into target tissue, of course not the T cups, caffeine, right? And it will inhibit phosphodiesterase. A result will be that breakdown of cyclic AMP will be slow and it will accumulate. Anyway, let's come back. We were talking about that this is adrenergic drive, how it can be countered by cholinergic drive. Again, let's see the balance. Sympathetic system stimulates, parasympathetic inhibit. This is working through, whenever sympathetic nervous system is stimulated to the heart, it is leading to inhibition of parasympathetic, and when parasympathetic is stimulated, it is leading to inhibition of sympathetic. Then both of them act on the same neurotransmitter, release a different. They release different neurotransmitter, and they act on the different receptors. And one receptor system, beta 1 receptor system stimulate G stimulatory, other G inhibitory, and both of them converge on uniform pathway, that is adenylyl cyclase, and adenylyl cyclase convert ATP into cyclic AMP. Then again there is a breakdown. Phosphodiesterase tend to break it. Then what is there? If cyclic AMP is there, it will lead to protein kinase A activity, and protein kinase A will lead to phosphorylation. Is that right? But once these cationic channels are phosphorylated, should they remain phosphorylated forever or not? Not. So there must be something we should break away phosphorylations. What is that? Counterbalancing system. Look at the beauty of biological system, multiple counterbalancing at molecular level, at neuronal level, at cell membrane level, right? What is the counterbalance here? If we have something to phosphorylate, there must be something to dephosphorylate. Something to phosphorylate in this example is protein kinase A. What is something to dephosphorylate? Yes, please, Dr. Shapper. Anyone who is good at biochemistry? You are studying biochemistry these days. Phosphatases simply. These are called phosphatases. These are phosphatases which will break down the phosphate from here. Now again, in the end, what is the balance? That adrenergic system lead to phosphorylation of cationic channels and cholinergic system lead to dephosphorylation of cationic channels. It means adrenergic system on SA node overload the SA node with, yes, adrenergic system overload the SA node with cations, and cholinergic system reduces the overloading of cations. If you really want to be too good, I want to tell you one thing. G inhibitory consists of 3 units. What are those? Alpha inhibitory, yeah, beta inhibitory and gamma inhibitory. When this is stimulated, alpha inhibitory lead to inhibition of adenylyl cyclase, and beta and gamma unit, when they are stimulated, they go and stimulate potassium channels. They will go and stimulate beta and gamma unit, they will stimulate potassium channels. And when this beta gamma sensitive potassium channels are stimulated, potassium will jump out because there is more potassium in the cell as compared to the outside. So it means that cholinergic system not only reduces cationic loading, it also enhances cationic deloading. Is that right? Not only it reduces sodium and calcium influx, it also increases potassium efflux. So what is the net result? Net result is too simple to understand. That adrenergic activity on the heart overload the myocardial tissue with cations, and cholinergic activity deloads the cations. So again balance. It means adrenergic system take the resting membrane potential towards threshold, and cholinergic system take the action potential away from threshold. Am I clear? Secondly, adrenergic system increases the chance of speed with which resting membrane potential can approach threshold, and cholinergic system decreases the velocity with which resting membrane potential can approach threshold. Look here, if I make this SA node, electrical activity, right? Now what really happens? If you are cation loading, this will become like this. So total number of action potentials are decreased or increased? So what will happen there? Tachycardia, because it is more rapidly approaching the threshold. But if there is, yes, what is this? Cholinergic activity. Lot of less cations coming in and more cations lost. So resting minimum potential is away from threshold and it will go rapidly up or gradually up? Very slowly. So it will take long time to total number of action potential which are produced are less and patient will end up with bradycardia. This is exactly how sympathetic nerve, parasympathetic nerve, then there is a balance between beta 1 receptor and muscarinic receptor, how they counterbalance each other at adenylyl cyclase. Sympathetic nervous system increases, cyclic AMP, phosphatases break down that, phosphodiesterase break down that, protein kinases phosphorylate the cationic channels and phosphatases dephosphorylate. In the end, SA node is stimulated or inhibited, it depends on what is the level of loading or deloading of cations on the excitable tissue. Okay, now we will be talking about parasympathetic nervous system. Parasympathetic nervous system, as you know already, this is one of the division of autonomic nervous system, and parasympathetic nervous system has many differences with the sympathetic nervous system. First I will talk about the basic anatomical detail of the parasympathetic nervous system, and then we will go into detail how they are different from each other. Again, the highest center for the parasympathetic outflow is also present in the central nervous system at the hypothalamic level. You know, let's suppose here is your hypothalamus. Now, you see the interior part of hypothalamus, this is mainly controlling the parasympathetic outflow, and posterior part of hypothalamus is mainly controlling the sympathetic outflow. And this is the balance in between these two things which determine a general level of autonomic control in our body. Now what really happens? That when we need parasympathetic activity, then polysynaptic descending pathway are emerging from anterior region. And these polysynaptic pathways, as they are going down, right, number one, they stimulate some parasympathetic centers which are present in brainstem. Then they stimulate another group of parasympathetic neurons which are present in lower part of pons, and a very important parasympathetic outflow which is present in medulla. Actually, this particular area in the upper part of midbrain, this is called Adinger-Westphal nucleus. What is this? Adinger-Westphal nucleus, right? And this particular area is called superior salivatory. This is superior salivatory or lacrimatory nucleus, and here it is inferior salivatory nucleus, and here is dorsal nucleus of vagus, right? Now, basically parasympathetic outflow comes from the brainstem, from which area? Number one, the highest outflow is from the midbrain, at the upper level of midbrain, and fibers come out along with which fibers? Third nerve, along with the third nerve, third cranial nerve, which is oculomotor nerve. Parasympathetic fibers are coming in the third cranial nerve, right? These fibers are taken from which outflow center? Adinger-Westphal nucleus. These are considered preganglionic fibers, right? And these fibers, as they will move forward, they will eventually end up into which ganglion? Ciliary ganglion. And from the ciliary ganglion, there will be postganglionic parasympathetic fibers which will come out as short ciliary nerve. They will come out as short ciliary nerve. If I really draw your eyeball over here, then what really happens that you know, here is constrictor pupillae muscle, and here is which muscle? Ciliaris. This is also here ciliaris. Now, Basically, from the, of course, you must be knowing this is your optic nerve. Now, what really happens that from the ciliary ganglion, short ciliary nerves come out and they pierce the sclera. Short ciliary nerves come out, they pierce the sclera and enter into eyeball. And they traverse forward short ciliary nerves between the choroid and the sclera. And as they are traversing forward, on the way, they will give innervation to ciliaris, and terminally they will give innervation to sphincter pupillae. Same is true over here, that short ciliary nerves, fibers are going on the way, they are giving branches to ciliaris, and their terminal branches should go to the sphincter pupillae. Now, here you have to understand. Basically, this parasympathetic outflow, it has a long preganglionic fibers and short postganglionic fibers. Actually, most of the parasympathetic fibers have long preganglionic fibers and short postganglionic fibers. That is why for parasympathetic nervous system, the ganglia are located usually away from the central nervous system, and ganglia are usually located more near to the target tissue. Even in some examples like GIT or in the heart, parasympathetic ganglia are present on the or within the wall of the viscera, right? Now, in this particular example, the fibers which end up on the, what is this, ciliaris, they release their acetylcholine, and ciliaris has muscarinic receptors, and these muscarinic receptors will stimulate the ciliaris. When ciliaris will contract, posterior part of the ciliaris will move forward and inward, and tension on zonule is increased or decreased? Is decreased. Again, when ciliaris will contract, right, posterior part of ciliaris will move forward and inward, and when it will move forward and inward, because interior ends are fixed, so when these posterior ends to which zonules are attached, when they will move forward and inward, then tension on the lens is reduced and lens will become globular. So whenever ciliaris is stimulated due to when you stimulate the Edinger West wall, if ciliaris is stimulated, it will contract, it will pull the zonules forward and inward, and tension on the lens capsule has been reduced. And if lens is pliable, as it happens in younger age, right, lens will become more globular. And if lens become globular, that will end up into what? Accommodation for near vision. I will be accommodating for near vision. So it means Edinger Westphal nucleus has one function, that it helps in accommodation for the near vision. Secondly, that within another subgroup of this Edinger Westphal nucleus, that gives second type of parasympathetic outflow, and second type of parasympathetic outflow that goes through short ciliary nerve, not to the ciliaris but beyond the ciliaris to sphincter pupillae. Again, these fibers, parasympathetic fibers, will be releasing acetylcholine on sphincter pupillae, and sphincter pupillae muscle, which is circular muscle, a sphincter muscle, it is having again M3 receptors or muscarinic receptors, right? And when those muscarinic receptors are stimulated, those lead to, again, you really want to know detail or you know it already? How do they really work? Who will tell me? When acetylcholine is released on the sphincter pupillae, sphincter constrict. Who knows the mechanism? Anyone can impress me. Should I draw it rapidly or I should go ahead? I should draw it rapidly. Okay, very rapidly. This is smooth muscle, right? Here is what? M3. What is this? Acetylcholine coupled with GQ. GQ stimulate phospholipase C. Phospholipase C break down the phospholipids into diacyl glycerol and inositol triphosphate. Inositol triphosphate act on endoplasmic reticulum, and when it acts on the IP3 sensitive pump from the endoplasmic reticulum, what goes out? Calcium, and calcium act on the contractile machinery of the cell, and cells will contract and sphincter will become tight. That's so simple. Is it difficult? Again, this is a calcium loading mechanism, but in a different way. Don't confuse it with the M2 receptors which are present on the heart. On SA node, AV node business, there was M2 receptors for acetylcholine. But on these smooth muscles which contract, like sphincter papillae or even all the GIT smooth muscles, you have heard of that GIT is stimulated by acetylcholine, or vagus is the motor to the GIT. And if someone asks you by mistake, of course you will be doing the mistake if he asks you that if vagus is stimulating the GIT, how? Answer is same. Vagus releases their acetylcholine, of course it stimulates intramural ganglion and myenteric plexus, and then what really happens? That acetylcholine released on the smooth muscles of GIT by postganglionic fibers. When acetylcholine released on the smooth muscle of GIT, now it can be considered smooth muscle of GIT. Action is same. That acetylcholine stimulating M3, stimulating GQ, stimulating phospholipase C, and phospholipase C breaking the phospholipids. Which phospholipids? Not everyone. Phosphatidyl inositol diphosphate. Phosphatidyl inositol diphosphate into diacylglycerol and IP3. IP3 will stimulate IP3 dependent. Yes, what is that? Endoplasmic pumps, and they will bring what? Calcium out. Calcium will bind with calmodulin. Calcium calmodulin kinases are activated. Kinases lead to phosphorylation of light chains of myosins, and the phosphorylated light chains of myosin overact with the actin and smooth muscle contract. Am I clear, or it's too fast? Clear? Is that right? So this is how cholinergic activity lead to smooth muscle contraction. This may be a smooth muscle of iris, or it may be a smooth muscle of GIT, or it may be smooth muscle of detrusor, or any other smooth muscle which is being contracted by the cholinergic drive. Am I clear to everyone? Right? So, can you tell me what is the mechanism, how it stimulates the ciliaris? Mechanism is again same, basic principles are same. Is that right? Okay, now we go ahead. The second outflow, okay, now we can say the first outflow from the brainstem is from Adinger-Westphal nucleus. Fibers go along the third nerve. Again, I would just remind you that in the third nerve, parasympathetic fibers are on superolateral part of the third nerve. It is the upper part of the third nerve which is loaded with the parasympathetic fibers. So whenever there is a tumor or any mass from the upper part of the brain which is irritating the third nerve, sympathetic fibers will under fire or over fire. Irritated parasympathetic fibers will overfire, and patient will produce meiosis. When there is a mass, if there is a mass, right, and this mass start irritating the parasympathetic fibers, there will be pupiloconstriction. But if this destroys the parasympathetic fiber, there will be pupilodilation. That is why pupiloconstriction in a patient with supratentorial mass is considered surgical emergency, right? Now, second important outflow is coming from, again it's a double outflow. This is lacrimatory outflow and salivatory outflow. These fibers are going with which nerve? Facial. This is going with facial nerve, 7th cranial nerve. Is it right? And of course, the fibers which are considered from lacrimatory nucleus, they will eventually end up into which ganglion? Pterygopalatine ganglion. From here, some fibers will go upward and supply, what is this here? Lacrimal gland. Okay, you do have tears. Crocodile tears or other tears? Okay, ladies' tears. Now what we are talking about, that in the 7th nerve, right, it is picking up the parasympathetic fibers from lacrimatory nucleus and superior salivatory nucleus. These parasympathetic fibers, some of these go to the pterygopalatine ganglion. Again, this was ciliary ganglion, this is pterygopalatine ganglion. From the pterygopalatine ganglion, some fibers will go to the lacrimatory pathway, and other fibers through the, they will go for nasal and palatal glands. Nasal and palatal glands. Of course, there is no fun in telling such an intelligent audience that these fibers will go through inferior orbital fissure, and these fibers will pass through sphenopalatine ganglion medially. or sphenopalatine foramen or pterygopalatine foramen. Did you know that or not? Okay, is that clear? Then we come to second group. Second group of parasympathetic fibers, which are again coming from the superior salivatory nucleus, and they are again going with the seventh nerve. They go through the middle ear, right, and then as a part of chorda tympani they come out, and eventually they go into which ganglion? Yeah, submandibular. From here, some fibers go to sublingual gland and other fibers go to submandibular gland. Here is your tongue, and of course under it what should be here? Sublingual gland. And what should be here? Submandibular gland. Right? So how many ganglion do you have? Ciliary ganglion, input is from Edinger-Westphal system through which nerve? Third nerve. Output short ciliary nerves for the accommodation and what is there? Pupiloconstriction. Second ganglion was pterygopalatine ganglion. Input was from seventh nerve. Source is superior salivatory or lacrimatory nucleus. Output is going to lacrimal gland and nasal and palatal glands. Third ganglion was submandibular ganglion. Again, input is through which nerve? Seventh nerve, chorda tympani, and source is superior salivatory nucleus, and destination is output goes to sublingual and submandibular gland. Then we come to, what is this? Inferior? Yes. And this is going along which nerve? Ninth nerve. Right? And this is from inferior salivatory ganglion, inferior salivatory nucleus from the lower pontine, and they will end up into which ganglion? Aortic ganglion. And from aortic ganglion, these postganglionic fibers will go, of course, through auriculotemporal nerve branch. Right? So they will go to the parotid gland. Right? So, parotid gland. Any question here? Now the most important, vagabond. Dorsal nucleus of vagus. It's one of the major parasympathetic outflow in the body. These fibers give parasympathetic outflow to which nerve? 10th nerve or vagus nerve. And these parasympathetic fibers which are going along the remaining component of the 10th nerve, they have to really supply a lot in the body. Let's suppose draw here a miniature human being. Okay, I will not go into detail. Some of these fibers, they are going to, pharynx, larynx, esophagus. Then, of course, you must talk about viscera in the chest. Some viscera in the neck, some viscera in the chest, some viscera in the abdomen. Right? So, in the chest, there is heart and there are lungs. Right? Then, if you come down in the abdominal cavity, there is stomach, duodenum, jejunum, ileum, and then they will end up into cecum, ascending colon and transfer colon. Right? Now, these fibers will come to all these organs. Okay, I will just make them again so that you feel better. Okay, let me make a person here. Right? Okay, heart should be put somewhere in between. Black heart, very sad person. Then here should be GIT. Duodenum, jejunum. Now, vagus has to supply, some pharyngeal glands, laryngeal, then it is, what is this? Lungs, of course, we should not forget. Vagus also takes some sensory fibers from here, which we will not talk about. But did you know some vagus takes some sensory fiber here? From the lungs, it is for inflation and distension, and from the carotid sinus fibers go back through the 9th nerve, and from the carotid body fibers go back to the 9th and 10th nerve. But we will not talk about those things. We will keep on. That vagus is having parasympathetic supply to the neck viscera, then to the chest viscera, then to the abdominal side. Of course, we should not forget supply to the heart. Then it is going to the small gut throughout. Then in the large gut, it is supplying up to the transverse colon, up to the splenic flexor. Or some people believe it early 2/3 of the transverse colon. Right? Along with that, all their associated other structures like liver, right, or other glands like pancreas, right, or renal tissue. So vagus is mainly, you can say, giving parasympathetic outflow for some of the neck viscera, then thoracic viscera and abdominal viscera, but lower abdominal and pelvic viscera are supplied by, yes, outflow from sacral units which are stimulated by descending pathways, right? As they were descending, from here descending pathways are coming. Some was stimulating, what was this? Dinger Westphal. Some are stimulating superior salivatory, some are stimulating inferior salivatory, some are stimulating, yes, dorsal. And then from all this cervical segment or thoracic segment or lumbar segment, parasympathetic do not give any outflow, right? Then in the sacral unit S2, 3 and 4, right, descending parasympathetic fibers stimulate the outflow. So what can we really say? That is craniosacral outflow. Parasympathetic outflow is craniosacral outflow because it is coming out through cranial nerves and coming out through sacral nerves, right? These sacral nerves, which are the last, they become pelvic nerves eventually. They are supposed to supply last part of the gut. Last part of descending colon. And what is this? Sigmoid colon, then rectum, right? Number 1. Number 2, they supply the urinary bladder, and number 3, they supply the genitalia. Is that clear? Any question up to here? And of course, allied structures and glands. This is basically your parasympathetic outflow. Now, first let's anatomically compare sympathetic and parasympathetic. Even though sympathetic and parasympathetic, both of them have one thing common, that their highest center is present at hypothalamus. But in a normal person who is resting and who is comfortable, not under stress, parasympathetic system is dominating. But when you are under stress, considerable stress, your sympathetic system starts dominating. This is one difference. Secondly, parasympathetic outflow is craniosacral outflow. And we discussed previously that sympathetic outflow is thoracolumbar outflow. Then another difference. Parasympathetic system can fire discretely, but usually sympathetic system fire diffusely. You cannot say that my sympathetic system is stimulating the lower limb but not stimulating upper limb. Or can you say it? Sympathetic system usually fires diffusely. But thank God, parasympathetic supply is not diffuse firing, discrete firing. For example, a lady who wants to lacrimate. So thank God she only lacrimates. She is not going to salivate and defecate and micturate everything simultaneously. Is that right? So we should be thankful to Almighty that parasympathetic system is unlike to sympathetic system, that it can work discretely. Or Dr. Arif goes for micturation. It's not necessary he should lacrimate also. Is that right? So parasympathetic, or when he is salivating, other activities are thank God off. So the beauty of parasympathetic nervous system, a very big point to differentiate it from the sympathetic is that it, thank God, it does not work diffusely, right? Many of its functions are independent. As I told you, you can lacrimate without having salivation, or you can salivate without having lacrimation. But of course, sometimes it happens, you end up with a very, very spicy and tasty food. Then what you do? You not only salivate, you may have little bit nasal secretions also, and with that you may have some lacrimation. Is that right? Anyway, now this was the first outflow, cranial sacral outflow. This was concerned with near accommodation and Meiosis. Second outflow was concerned with lacrimation and salivation. Third outflow, which was lower salivatory nucleus to the ninth, right, it was again salivation. This outflow, which is parasympathetic, dorsal nucleus of vagus, it is for secretions of the glands in the neck, esophageal glands, or you can say pharyngeal glands, or trachea or bronchial tree, parasympathetic supply, or you can say to the heart, it produces bradycardia. And again, there's a very important thing about the parasympathetic and sympathetic supply to the heart. There's a difference in sympathetic and parasympathetic supply to the heart. Let's talk about this. Is very interesting thing. It's worth learning because many concepts in cardiology are related with this basic thing, how autonomic nervous system is dealing with the heart. In the heart, there's the SA node, yes, there's AV node, and Purkinje fibers, right? Okay. Now, sympathetic supply goes to, yes, what is this? SA node. It goes to atrium. Sympathetic receptors are also present on AV node. Sympathetic receptors are also present on Purkinje fibers, and sympathetic fibers are also present on generalized ventricular myocardium. Is that right? Clear? Opposite to that, parasympathetic supply is not so diffusely present on the heart. Parasympathetic fibers are mainly concentrated on the SA node, and number two, they're mainly concentrated on the AV node, and very few on atrium, and almost non-existent to ventricle. So it means when you have sympathetic drive, it will have, look here, sympathetic drive, it will have positive chronotropic action, it will have positive dromotropic action, sympathetic supply will have positive bathymotropic action, and it will have positive inotropic and clinotropic action. But when you have stimulation of parasympathetic nervous system, it will have opposite to that, but not all the component. When you have parasympathetic stimulation, there is negative chronotropic action, there is negative dromotropic action, but don't tell anyone that vagal stimulation will end up into negative inotropic action. Sympathetic stimulation has a positive inotropic action, but parasympathetic does not have negative inotropic action. Is that right? Or negative bathymotropic action, or negative clinotropic action. So what we have to really learn, that as far as heart is concerned, again sympathetic receptors are diffusely present on the myocardium, but parasympathetic fibers are specially concentrated on SA node and AV node. Is that right? Now I want to ask one interesting question. These are what are these things? Right bundle branch and the left bundle branch. Dr. Maliha is going to tell us that these bundle branches are, I will give you a choice. You have to choose any one. These bundle branches are made of, number one, fibrous tissue, number two, neuronal tissue, number three, myocardial tissue. Choice number 1, 2 and 3. Yes, please. They are neuronal tissue. This is the answer by Dr. Maliha. What about you? That these bundle branches, they are made of fibrous tissue, they are connective tissue fibers, or they are neuronal fibers, or they are myocardial fibers? Hurry up.
No, number one.
Number one, you feel it's connective tissue fibers. Question goes to you, ma'am. Any idea? Again, I will repeat the question. The bundle branches are made of connective tissue, or made of neuronal tissue, or made of myocardial tissue? These are neuronal tissue. What about you, ma'am? Neuronal tissue. Yes, madam? Neuronal tissue. Another madam is there? Neuronal tissue, thank God democracy does not decide about the medical facts. Yes, please. It's specialized myocardial tissue. Thank God, at least there's a person who knows it. It's so sad. Don't tell me these are cardiac nerves. This is not neuronal tissue. Then I have to tell you a very basic thing. Myocardium is divided into two types of myocardium. Specialized myocardium and generalized myocardium. Specialized myocardium is modified myocardium which has done some specialist function. Listen carefully. SA node is modified specialized myocardium which has done specialization in automaticity. Automaticity means it is specialized in producing spontaneous section potentials. Automaticity means a tissue has a tendency to undergo auto-depolarizations. AV node is specialized myocardium. What is its specialization? Slow conduction. It makes the conduction very, very slow. It holds the current until atrium complete their contraction and throw the blood into ventricle. Then AV node releases the current into ventricle, so that first atrial contraction should be complete and then ventricles should contract. Is that right? And bundle branches. They are also specialized in myocardium, but specialized in fast conduction. Oh my God, I have to teach cardiology. Right? So what is this? These are specialized myocardium which are specialized in fast conduction. And of course then there is ventricular fibers which are just normal myocardium, general myocardium. Don't tell me this is connective tissue, please. Connective tissue act as an insulator. So how the current will pass through that? Am I right, ma'am? Right? Connective tissue is this black one. This black septum is connective tissue. This does not allow the free movement of current down. The only electrical window between the atrium and ventricle is your AV node, which is specialized in slow conduction. And Purkinje fibers are specialized in fast conduction. SA node is specialized in automaticity. Now let me tell you something interesting. This is normal myocardial cell. What are its function? It can show some automaticity on provocation. It can show some conduction. It can show some contraction. But it is not specialized in automaticity. It is not specialized in slow or fast conduction. Normally, atrial fibers and ventricular fibers do conduct with moderate speeds. They are not specialized in slow conduction or fast, but they do contract as well. SA node fibers have lost the capability of contraction, but they have developed the capability of high automaticity. This has developed capability of slow conduction. These fibers have developed high capacity of fast conduction. Then you would ask why this is slow and this is fast. We'll talk later, but just I want to tell you, here the cells are smaller in size, here the cells are larger in size. Here the cells have less gap junctions, here the cells have a lot of gap junctions. So electrical window here is very few and here they are very. Are you getting me or not? You're really getting me. Yes, what about you? You're understanding. You know, cell to cell there are electrical windows. The cells which are present in AV node, they are arranged like this and there are very few electrical windows. And cells are against the current flow, perpendicular, so current flows very slowly. But in bundle, in these fibers, cells are very large and they have a lot of gap junctions and they have big diameter and less cells are traveled. I mean, cells are oriented along the current flow. Is that right? So simply by making the cells small and by making the cells with less electrical windows, which are gap junctions, and by making the cells orientation against the current flow, you make AV node. By making the cells larger, making them big diameter so that current moves with less resistance, making the cells oriented along the current flow and making the cells with a lot of electrical windows, gap junctions, makes them specialized in fast conduction. Is that right? Why I was so much concentrating on this thing? Because good students should know that adrenergic receptors are present in all the myocardium, SA node, AV node, atrial, ventricular and Purkinje system. But vagal activity is mainly on these two specialized areas, SA node and AV node. That is why when vagus is too much stimulated, it may lead to bradycardia. And if it becomes so much inhibited, no current from here to here is going, then we say heart block or nodal block or junctional block. You can choose whatever you want. These three terms are used. Is that right? Am I clear? But don't tell anyone that because vagus was stimulated, myocardium does not contract. Vagus does not affect the myocardial contractility. Am I clear? Okay, let's come back. So we were talking about here that vagus has good supply. Okay, there are how many vagi there? Two. There's right vagus and left vagus. Right vagus supplies which part of the heart? Question goes to yes, madam. Okay, she is a very simple lady. She says right vagus should supply the right side of the heart and left vagus should supply the left side of the heart. Can you be more elaborate about this answer? Right vagus supplies which part of the heart? Yes, please. I'm about to die. Yes, please. Right vagus supply which part of the heart? Okay, there is a new theory which no one in the world knows. She says right vagus does not supply the heart. Right? Okay. This is totally new. No one knows in the world. Yes. Yeah, you know, the doctors have came with a new idea. There's a milkshaker there and it's mixing both vagi and then supply. Yes. Please tell me. SC node is supplied by the right vagus and AV node is supplied by the left vagus. It's such an important clinical thing. When it's so important, I don't know how to further emphasize it. Right vagus supplies SC node and left vagus supplies dominantly AV node. I will not go into embryology of heart, of course. Right? Now you come over here. Let's go to the abdomen now. It's enough from the respiratory system. Now we come to the abdominal cavity. It has some viscera as well. Now, vagus is supplying to the small gut, all of it. It's supplying the stomach, duodenum, jejunum, ileum. Then, of course, cecum, ascending colon, transverse colon, lot of it, right? And associated all glands, which may be pancreas or liver and other associated allied structures. What vagus is doing over there? It is releasing acetylcholine. When acetylcholine releases on the smooth muscles, that leads to contraction of smooth muscles and it produces more motility. So vagus is, yes, motor to GIT. Not only it is motor to GIT, it is secretomotor to GIT as well, because vagus also releases acetylcholine on the glands, which may be gastric glands or which may be your succus entericus producing glands or pancreatic glands and bile producing liver, of course. So all the glands are also allied structures and their glands, they are loaded, studded with the terminals of vagi, right? Stomach, duodenum, jejunum, ileum and ascending cecum, ascending part of colon and transverse part of colon and related glands. Of course, when glands are also stimulated, glands have what kind of cholinergic receptors? Yes, please. Glands at what type of receptors? I think M1 are present on the parietal cells, right? Others are having M3, right? Anyway, these also lead to the calcium loading. And you know, when glandular cells are loaded with calcium, they release their secretions. There's no fun in telling this thing, you already know, right? So it is, vagus is motor to GIT as well as secretomotor to GIT. It increases the, and if vagus really is for someone overwork, it may produce what thing? Vagus if it overworks. Someone's vagus to the parietal cell overwork, produce excessive HCl, which may be one of the reason for the peptic ulcer. Is that right? Anyway. Then we come to, but peptic ulcer has many other reasons as well and mechanisms as well. We will not go into detail of that. Now, from here we come to sacral outflow. In sacral outflow, it is from S2, S3, S4. Fibers are going through the pelvic nerves. Which ganglion is present over there? Yes, parasympathetic fibers which are coming through the pelvic nerves. These are also called nervi argentis. Which ganglia is on the way? Here it was ciliary ganglion, then there was, yes, pterygopalatine ganglion, then there was submandibular ganglion, then there was aortic ganglion. For vagus, which ganglia were there? Intramural ganglions, right? Vagus goes right up to the target tissue and there as ganglia present on the heart or within the walls of the bronchi or within the wall of the GIT and very small, what is there? Postganglionic fibers are there, right? Then, yes, I was about to be impressed by someone that these pelvic nerves, they have a ganglion on the way. Where is the ganglion? What's the name of that ganglion? I think Dr. Saab knows that. Yes. Anyone, feel free to answer. Yeah? Hypogastric ganglion. Write it down. Hypogastric ganglion. Don't cut it. Just write it down. It is not for parasympathetic, it is sympathetic. You know, there's pelvic sympathetic ganglion also. You know, the sympathetic ganglion are number one, sympathetic chain. Number two, the prevertebral sympathetic ganglion we discussed last time. And preganglionic sympathetic, prevertebral sympathetic ganglion are celiac ganglion, superior mesenteric ganglion, inferior mesenteric ganglion, and hypogastric ganglion. So you have told the right answer, but for a different Question. The question should be, what is the ganglion for the sympathetic supply to the pelvic? Viscera, of course, right? So again our question is there, that hypogastric ganglion is for which fibers? Sympathetic. For example, if I say there's sympathetic supply going to the urinary bladder, of course ganglion is hypogastric. But please tell me, what is the name of the ganglia through which S2, S3, S4 gives its supply? It's a very important supply, you know. It's concerned with defecation, it's concerned with micturition, and if it is concerned with genital activity. Dr. Saab is knowing this extremely important area. So where is the ganglia? Intramural. He's right. Just by chance he is right. At last. The point which I want to highlight, don't look in the pelvis for ganglion, which is parasympathetic ganglion. Have you heard of, when you are studying anatomy of the pelvis, that there are parasympathetic ganglion there? There's hypogastric ganglion, but every ganglion is not parasympathetic. Some of them are sympathetic, and hypogastric is sympathetic. Then intramural, the very long preganglionic fibers, very short postganglionic fibers. Is that clear? No question? Okay. And there's no fun in telling that these fibers are concerned with motor to last part of GIT leading to defecation, and to the bladder they will lead to micturition, and for the genital activity in the male, parasympathetic activity will lead to erection, and in female that will lead to vaginal secretions, right?